Senate Committee on Health, Education, Labor, and Pensions will come to order. Today we are going to be discussing one of the major health crises in America, and that is the diabetes epidemic that is having a huge impact on our country and an issue that must be addressed. Diabetes, as I think we all know, is not only a serious illness unto itself, but it is a contributing factor to heart disease, stroke, amputations, blindness, and kidney failure. Type 1 diabetes is a major problem that impacts over 1.4 million Americans, and we're going to be discussing that issue today. And my understanding is that Senator Cassidy has brought two witnesses who are extremely knowledgeable about type 1 diabetes, and we look forward to hearing what they have to say. My focus is going to be on type 2 diabetes, which impacts about 95% of Americans who have diabetes. There is obviously a whole lot that can be said about diabetes, but here are just a few of the questions that I hope we will dive into this morning. First, and maybe most importantly, why have we seen a huge increase in the number of people in America who have developed diabetes over the last 50 years? What's going on? What has changed? I think that maybe is the most important question. Secondly, how is diabetes impacting our healthcare system? And I think we know some of those answers. Thirdly, given the huge number of people who are struggling with diabetes, how can we make the treatments, and there are some very effective treatments out there, how do we make them available to everyone who needs them regardless of their income? And further, when we talk about the cost of treatments in diabetes, we are cognizant of the fact that Medicaid and Medicare and other public health programs spend huge amounts of money for those treatments, as do private health insurance companies. So how do we make sure that we don't bankrupt Medicare and Medicaid in the process of treating diabetes? First, the problem. Today in America, rather remarkably, we have over 35 million Americans, that's over 10% of our population, who have type 2 diabetes. And the cost of treating that disease is absolutely staggering. According to the American Diabetes Association, the total cost of diabetes in the United States was nearly $413 billion last year. $413 billion. And that's up 27% over the past 6 years. And that amounts to about 10% of our overall healthcare costs. So $1 out of every $10 spent on healthcare is dealing with diabetes. And when we talk about the type 2 diabetes epidemic and the huge increase in new cases, we must also talk about another epidemic, and that is the epidemic of obesity in America. Some 90% of people with type 2 diabetes are overweight or obese. These two epidemics go hand in hand. A key question that we must discuss: how did it happen, according to the CDC, that the rate of childhood obesity in America has tripled since the 1970s, and has gotten so bad that 1 out of every 5 children and over 40% of adults in our country today are now obese? Why is it that, according to the CDC, the number of children in America with type 2 diabetes is estimated to skyrocket by nearly 700% over the next 40 years unless we get a handle on that issue? That's just an extraordinary number. The answers to those questions are not complicated. Difficult, but not complicated. For decades, in my view, we have allowed large corporations in the food and beverage industry to entice children to eat foods and beverages loaded up with sugar, salt, and saturated fat, purposely designed to be overeaten. The situation has gotten so bad that most of what children in America eat today consists of unhealthy, ultra-processed foods that doctors have told us lead to a higher risk of type 2 diabetes. Alarmingly, according to a recent study that will be discussed this morning, ultra-processed foods, which make up an incredible 73% of our nation's food supply, can be as addictive as alcohol and nearly as addictive as cigarettes. While the diabetes and obesity rates in America soar, while we spend hundreds of billions of dollars to treat diabetes, the food and beverage industry spent $14 billion last year on advertising to make many of their unhealthy products appealing to the American consumer. Even worse, and I think really what gets to me, $2 billion of their advertising budget is used to directly market food predominantly high in sugar, salt, and saturated fat to our children in order to get them hooked on these products at an early age. How's that? According to the Rudd Center for Food Policy and Obesity, children and teens view about 4,000 food and beverage ads on television every year, an average of 10 advertisements each day. Another study found that children who watch Nickelodeon and Nicktoons are exposed to over 10 unhealthy food and beverage ads every hour. They're going after the children. Let me give you just one example. Last year, for example, Coca-Cola spent $327 million on advertising in the United States alone. Not one of those ads will tell you that drinking 1 or 2 cans of Coke a day will increase your chances of getting type 2 diabetes by 26%. I didn't quite see that in those lovely ads that they do. Nor will their TV ads tell you that one 20-ounce bottle of Coke contains over 15 teaspoons of sugar, more than twice the recommended daily limit for kids under the age of 18. Nearly 30 years ago, as I think we all know and the American people know, Congress had the extraordinary courage, and it was not easy, to take on the tobacco industry, whose products killed over 400,000 Americans every year, including my father. Congress had the courage to do that then. Now is the time for us to seriously combat the type 2 diabetes and obesity epidemics in America. In order to do that, we must have the courage to take on the greed of the food and beverage industry, which every day is undermining the health and well-being of our children. As adults, as responsible people, as representatives of the American people, we have got to do that. And in my view, a good place to start would be to ban junk food ads targeted to children. Now, this is not a radical idea. The NIH has estimated that if the United States banned fast food advertising marketed to children, talking about kids, we could cut the childhood obesity rate in our country by up to 18%. In the 1980s, Quebec banned junk food advertising to children. Today, Quebec has the lowest childhood obesity rate in Canada and the highest consumption of fruits and vegetables of any province in their nation. Ireland, Sweden, South Korea, Taiwan, Spain, Portugal, and several other major countries throughout the world have either seriously restricted or banned junk food ads targeted to children. In addition to addressing the causes of type 2 diabetes, there is another important issue that we have got to address. We have got to make certain that the treatments available to people with diabetes are affordable for all Americans and are not bankrupting federal health insurance programs or raising the cost of private insurance. The very good news is that a new class of treatments for diabetes and obesity, like Ozempic and Mounjaro, have the potential to be a game changer with respect to these major epidemics. According to clinical trials, these drugs, which suppress appetite, have been estimated to help people lose 15 to 20% of their weight. That's the good news, and it's importantly good news. The bad news is that these drugs also have the potential to bankrupt Medicare and the American people. According to research published in the New England Journal of Medicine, if just 10% of people with obesity on Medicare took these drugs, it could cost Medicare up to $27 billion a year, driving Medicare premiums way, way up. Further, incredibly, these drugs, Ozempic and Mounjaro, are up to 15 times more expensive in the United States than they are in other major countries. Let me repeat, these two important drugs, up to 15 times more expensive in the United States than in other countries. Ozempic, manufactured by Novo Nordisk, costs $12,000 a year in the United States. You know what it costs in Germany? $750 a year. Mounjaro, manufactured by Eli Lilly, costs $13,000 in the United States, costs $2,000 a year in the United Kingdom. Incredibly, it has been estimated that Eli Lilly, Novo Nordisk, and others in the pharmaceutical industry stand to make as much as $150 billion off of these drugs each and every year by charging us by far the highest prices in the world for their products. This is, to my mind, unacceptable for so many reasons. And that is why I am going to be introducing legislation which is very simple. It's legislation that says that here in the United States, we cannot continue to pay the highest prices in the world for prescription drugs. We should not be paying more than other major countries. And if that bill were to be signed in law, we would lower the cost of prescription drugs in this country by 50%. So that is where we are today. We have two issues. What is the cause of the epidemic, and how do we make sure that we have treatments available to all? I very much thank all of the panelists for being here. This is a very important issue, and I look forward to this discussion. Senator Cassidy, the mic is yours.
Thank you, Chairman Sanders. The obesity epidemic is quite remarkable. And type 1 diabetes, obviously not related to obesity, but nonetheless part of that which we're addressing today. And if you look at a kind of a map of the United States over the last 3 decades and the prevalence and incidence of diabetes, it just lights up, goes bigger and more intense, et cetera, however you look at the map. So it's a bipartisan issue. I'm glad the committee is addressing it. I will say, however, that the focus of the hearing has changed from our original agreement to explore the prevention, treatment, and management of diabetes from a clinical and public health perspective. Diet and access to healthy foods are important, but I will point out that corporate marketing practices to consumers and human nutrition are not the jurisdiction of this committee. Those are under commerce and agriculture. Food marketing is what this committee will focus on today. But ideally, the committee's time would be addressing issues over which we have legislative authority. If we have legislative authority, we can do something. If we have a hearing on something over which we have no legislative authority, we have a hearing. So I'll also point out, though, that our colleagues, Senators Susan Collins and Jean Shaheen, have led the Special Diabetes Program reauthorization, which the committee did successfully vote out in June. When enacted, it will provide additional mandatory resources for diabetes research at NIH. I'd also like, and that would be a good thing to have discussed today, how the NIH is using its discretionary funding, because that's something over which we do actually have jurisdiction. We should look at why NIH habitually underfunds obesity research, despite it being the kind of foundation of why the rate of type 2 diabetes has gone up so dramatically, as well as, by the way, its impact upon many other medical conditions. It's important to explore the impact of recent medical advances upon the lives of diabetics. American medical innovation is saving countless lives. Diabetes is no different. Groundbreaking developments in diabetes management, like the continuous glucose monitor, or CGM, increases patient adherence to treatment while improving quality of life for patients and peace of mind for parents and caretakers. We could familiarize ourselves more with that. I'm a doc, but I wasn't aware of it. And then somebody says, oh, no, you look on your phone. You can see what your diabetes is. It kind of really brings it home to the folks. And it was quite remarkable, my internist friends explaining to me how this has been so changing, so positive of a change in terms of the management of diabetes. We can point out that even 10 years ago, parents were worried about their children developing diabetic shock. But now with affordable CGMs and other innovative devices, blood glucose levels are monitored in real time, and these devastating occurrences such as diabetic shock are prevented. We need to continue to foster innovation and the solutions it creates. CGMs are miracles to many now, But at some point, it will become yesterday's news. We need the next miracles. Cellular treatments are on the horizon, and we have the potential to again revolutionize how Americans live with diabetes. I visited an outfit in Massachusetts, and they showed me this kind of twirling bath. And they said those are islet cells that can be gathered up and injected under someone's arm. And this is a technology that will be implemented. Quite remarkable. Again, we could have been discussing that today. The task of this committee is to balance affordability with innovation. I accept the chair's point. If there's an innovation that someone cannot afford, it is as if that innovation doesn't occur. So I'm with you on that. But we should, again, be discussing topics within the committee's jurisdiction. That's what we have the responsibility to do. And if there's something that we can actually address, then consider legislation. I look forward to exploring the issues that we can address with our witnesses. With that, I yield.
Thank you very much, Senator Cassidy. Now we're going to hear from our very distinguished and knowledgeable witnesses, and we're delighted they're with us today. Our first witness will be Dr. Ashley Gerhardt, who is a professor of psychology and clinical science at the University of Michigan. Dr. Gerhardt's research focuses on the effects of poor nutrition on diabetes and obesity, and factors driving excessive consumption of unhealthy foods. Notably, she has published a recent study on how ultra-processed food can be as addictive as nicotine and alcohol. Dr. Gerhardt, thanks so much for being with us.
Chairman Sanders, Ranking Member Cassidy, and distinguished members of the committee, thank you for the opportunity to participate in today's meeting. To begin, I will briefly review my qualifications to speak as an expert at this hearing. I received my PhD in clinical psychology at Yale University with a focus on addictive disorders, obesity, and disordered eating. I'm currently a professor of psychology and the director of the Food and Addiction Science and Treatment Lab at the University of Michigan. I'm also a licensed clinical psychologist. Through my clinical experiences, I have gained a firsthand understanding of how hard people are working to try and get control over their eating. I saw that even when people were faced with life-threatening health conditions like diabetes and were very motivated to change, they still failed to do so. My research has been built on the parallels between what I observed in the clinic and my scientific training on how certain substances can trigger addictive processes. In my research, I use multi-method approaches to explore the neurobiological, psychological, and behavioral factors that contribute to compulsive overeating and its negative consequences like obesity and diabetes. The American food supply has changed dramatically over the last 40 years. The American diet is now composed mostly of ultra-processed foods. Ultra-processed foods are industrially manufactured products created by deconstructing foods from their component parts, modifying them, and combining them with a myriad of additives. The resulting ultra-processed foods contain little, if any, whole foods, and they are a major source of added sugars and saturated fats in our diets. The average American adult and child gets the majority of their calories from ultra-processed foods. Ultra-processed foods have been implicated in health conditions like depression and obesity across numerous studies. Based on an analysis of 400,000 people, every 10% increase in ultra-processed food intake is associated with a 12% higher risk of type 2 diabetes. There are strong parallels between addictive substances and ultra-processed foods. Addictive substances are created through processing natural substances, like fruits or leaves, into new products that rapidly deliver unnaturally high doses of reinforcing ingredients into the body, like nicotine and cigarettes. Ultra-processed foods are similarly created by altering natural substances, like fruits and grains, into products that deliver unnaturally high doses and combinations of carbohydrates and fats, which are then rapidly digested by our bodies. Additives further enhance the flavor and texture of these ultra-processed foods and make them shelf-stable, accessible, and convenient. Basic neuroscience finds that ultra-processed foods, high in carbohydrates and fats, activate reward systems in the brain in an analogous manner to addictive substances like nicotine. Key signs of addiction occur in our intake of ultra-processed foods. Systematic reviews of over 280 studies estimate that 14% of adults and 12% of children meet the criteria for an addictive disorder in their intake of ultra-processed foods. This includes losing control over intake, intense, almost irresistible cravings, and an inability to reduce intake despite serious negative consequences. This addictive pattern of ultra-processed food intake is associated with a more than 5 times greater occurrence of type 2 diabetes. I want to provide a representative quote from a research participant from my lab. She said, "I can't even be in the same vicinity as a donut store or any type of donuts because I will finish a dozen all by myself. And I'm a type 2 diabetic, so that could kill me. I know that, and I know that I shouldn't be eating all of those. I shouldn't be eating one, let alone a whole dozen. But for some reason, I just can't stop eating them." If addictive mechanisms are being triggered by ultra-processed foods, this may be an overlooked reason why it can be challenging to reduce intake, even in the face of health conditions like diabetes. There are also strong connections between the tobacco and processed food industries. From the 1980s to the late 2000s, tobacco companies like R.J. Reynolds and Philip Morris became the biggest producers of processed food in the world. Internal tobacco industry documents demonstrate strategies designed to develop and sell cigarettes were applied to their processed food and beverage holdings, such as adding flavor enhancers developed for cigarettes into children's sugar-sweetened beverages, and increasing targeted marketing to children and racial ethnic minorities. Lessons learned from the tobacco epidemic can help guide solutions here. Investing in science to understand how ultra-processed foods activate mechanisms of addiction and contribute to excessive intake is important. Multi-pronged approaches and a focus on prevention, particularly for youth, will be important for improving Americans' health. Thank you for your time.
Thank you very much, Dr. Gerhardt. Our next witness will be Dr. Lindsay Smith Telly, Associate Professor in the Department of Nutrition at the University of North Carolina at Chapel Hill. Dr. Telly is a nutrition epidemiologist who evaluates food policies and the industry's influence on consumer choices. Dr. Telly, thanks so much for being with us.
Chairman Sanders, Ranking Member Cassidy, and distinguished members of the committee, thank you for the opportunity to speak with you. My name is Lindsay Smith Telly, and I'm a nutrition epidemiologist who works in the U.S. and globally. My research focuses on understanding how the food industry and the food environment influences nutrition, particularly among kids, as well as what policies work to create healthier diets. In every country where I work, one thing is true: parents want to make healthy choices for their kids. However, the current food environment makes it nearly impossible. Diets are a major driver of obesity and type 2 diabetes, and this problem is especially alarming for kids. In the US, pediatric type 2 diabetes has doubled over the last 2 decades. Healthier diets prevent diabetes and are more cost-effective than medication. So why don't we change our diets? First, our food supply. Most of our packaged foods are ultra-processed, and nearly half are too high in added sugar, sodium, and saturated fat. Our food contains more sugar and sweeteners than other high-income countries. We can't make healthy choices if healthy food is unavailable. Second, these products are aggressively marketed to children and disproportionately targeted to Black and Hispanic youth. Food companies spend $14 billion a year on food advertising in the US, of which 80% is for unhealthy foods. Marketing is powerful. It makes kids want unhealthy foods, and it makes them consume more of them. Third, kids still get mostly ultra-processed foods at school. Unhealthy food marketing inside schools is also very common. This serves to hook kids on unhealthy foods at a very early age. It's also very hard for parents to know what's healthy versus unhealthy. Nutrition claims like 100% all natural are very common in our food supply and lend an aura of healthfulness even to unhealthy foods. Meanwhile, the Nutrition Facts Panel provides useful information but can be hard to understand. Parents can't make informed choices without accessible information. Another major factor is price. Ultra-processed foods tend to be cheaper than healthy foods. Even though parents want to buy healthy foods, they buy ultra-processed because it's cheaper. Right now, the price of these unhealthy products does not reflect the health cost of consuming them. Lastly, the food industry has interfered with science and policy. Companies have paid to play by funding professional societies and research scientists to change the narrative about what causes obesity and diabetes. They also position themselves as part of the solution through voluntary initiatives, despite overwhelming scientific evidence that these programs are ineffective. So how can we fix this? We already have good data on what works. First, the U.S. should require clear nutrition labels on the front of food packages, a policy that the majority of Americans support across political parties. The FDA is currently researching front-of-package labels for the U.S. However, many of the designs that the FDA is focusing on are not based on the scientific evidence from the 10 countries that have implemented these labels, nor the many experiments we've conducted in the U.S. For example, several of the proposed FDA labels include numbers or color schemes that research shows consumers do not understand. In contrast, simple nutrient warnings like those in Mexico and most of South America are well understood even by children. In addition, in countries with these labels, the food industry has cut sugar, sodium, and saturated fat with no adverse effect on the economy. The FDA needs to work closely with scientists to develop evidence-backed labels that are easy to understand and clearly signal to consumers when products are unhealthy. Second, the U.S. should limit unhealthy food marketing to kids, much as it has for tobacco. Restricting where ads appear and the use of techniques like cartoons cut kids' exposure and helps them develop healthy preferences. Also, companies should not be allowed to take tax deductions on what they spend on food advertising. Third, our kids deserve classrooms that are free from corporate food. We should restrict the marketing, promotion, and sale of ultra-processed foods in schools, which global data show reduces their availability and improves children's diets. We also should use economic pressure to shift the food supply. Just like in tobacco, poor diets create massive healthcare burden and health costs in the U.S. And as in tobacco, taxes on the production of sugary drinks and ultra-processed foods would make food companies pay the true cost of these products. Global data show that these taxes spur companies to create healthier products and reduce the consumption of unhealthy foods. To further support diabetes prevention, revenue from these taxes could be used to fund fruit and vegetable subsidies for low-income families. Lastly, we need more funding for nutrition research. Even though nutrition is the leading cause of obesity and diabetes, only a tiny fraction of the NIH budget goes towards nutrition. Additional research funding is critical to improving diets and preventing obesity and diabetes. In conclusion, kids should not be sick because of our food environment. Federal policy action is urgently needed to make the healthy choice the easy choice. Thank you.
Thank you very much. Our next witness is Dr. Kasha Lipska, Associate Professor of Medicine at the Yale School of Medicine, and we thank her very much for being with us.
Thank you. Chairman Sanders and Ranking Member Cassidy, I am Dr. Kasha Lipska, physician scientist at the Yale School of Medicine. Thank you for the opportunity to present my testimony. As a clinician, I take care of patients who already have developed diabetes. There are now over 35 million people with type 2 diabetes in our country. Nearly 1 in every 3 older adults has diabetes. My focus with patients is to reduce the risk of complications of diabetes, such as heart attacks, strokes, amputations, kidney failure, and blindness. One of the biggest challenges in my clinical practice, including this past year, is still figuring out how to get my patients access to affordable treatment. Even the best medications cannot help patients if they cannot afford them. According to a national survey in 2021, 16.5% of people with diabetes rationed their insulin because of cost. This is not just due to lack of insurance coverage. Among Medicare beneficiaries with diabetes, 1 in 10 reported skipping, delaying, or taking less medication to save money. There has been so much excitement about the new medications in type 2 diabetes and obesity. That's because some of the medications, including semaglutide or Ozempic, really seem to work. They not only help people lose weight, but also, importantly, reduce the risk of complications related to diabetes and obesity. But the price tags for these new medications are simply outrageous. Ozempic, the brand name for semaglutide, approved for type 2 diabetes and marketed by Novo Nordisk, has a US list price of over $900 per month. Wegovy, the brand name for the same drug approved for obesity, is $1,300 per month. If Medicare were to fully cover Wegovy for all of its beneficiaries with obesity for 1 year, we as American taxpayers would end up with a $268 billion invoice. To give you some perspective, that's 70% of all the money that was spent on prescription drugs in the US in 2021. And could we stop at 1 year? Probably not. What we know about semaglutide and the related medications is that they work while people take them. However, as soon as they stop, their weight comes back. So patients are looking at a potentially lifelong treatment. And we could be facing the most expensive subscription service in the history of medicine. What can Congress do to fix this? Ozempic is priced at roughly $100 per month in Sweden and just $80 in Australia and France. That's 10% of what we're being asked to pay. One explanation is that those governments are negotiating prices directly with the pharmaceutical companies. That's not socialized medicine. That's smart negotiating. Price negotiation is critical, but I believe we must do more. Pharmaceutical companies have absolutely no restrictions on the launch prices of their products, nor is there any evidence that these prices are reflective of research and development costs. No amount of expert negotiation can bring down drug prices years later when the launch price is sky high to begin with. We have to align the launch price with the drug's value, the cost to develop and manufacture the drug, and what patients can afford. This is a rational approach that is in place in many other developed countries. But I want to be clear here. Medications alone cannot be the solution to the diabetes and obesity epidemics. We need to be more farsighted and strategic than that. Neither diabetes nor obesity is a moral failure or a personal choice. Just telling people to eat less, exercise more is not going to solve the problem. Instead, we must address the upstream causes of obesity, like holding the food industry accountable, as my fellow experts have already made clear. The reality is that the drug industry is really good at pushing its solutions and its products. Drug companies are powerful, sometimes more powerful than governments. Novo Nordisk, which is based in Denmark, now has a market value that is bigger than its host nation's GDP. So we must remember that drugs alone can't save us. They are only part of the solution. We can't simply prescribe our way out of this problem. And before we sign up for that never-ending subscription service and spend trillions of dollars, let's be smart consumers and have the government at the negotiating table right from the start. In closing, the bottom line is this. We have a food industry that profits from making people sick and a drug industry that profits from treating them. We must break that cycle. Thank you.
Thank you very much. Senator Cassidy, you want to introduce your witnesses?
Yes, thank you, Mr. Chairman. Pleased to first introduce Mrs. Natalie Stach, a mother to a type 1 diabetes patient. Mrs. Stach provides an insightful personal perspective on the issues children with type 1 diabetes and their parents encounter. In 2015, Mrs. Stach's daughter, Nadia, was diagnosed with type 1 diabetes, and apparently your family has a strong family history of this, of type 1, unrelated to obesity. Natalie volunteers with JDRF, the Juvenile Diabetes Research Foundation, to advocate for type 1 diabetes research. Earlier this year, she served as chair of the JDRF's Children's Congress. She lives in Texas with her husband and 3 kids. Thank you for joining us. I look forward to your testimony.
Chairman Sanders, Ranking Member Dr. Cassidy, members of the committee, thank you for inviting me to testify today. I'm here because, unfortunately, I am deeply familiar with the many challenges presented by type 1 diabetes, or T1D. I do not have this disease, but my 11-year-old daughter Nadia does, and she lives with it. My brother died from complications of T1D when he was only 38 years old, so you can imagine the fear that I felt when Nadia was diagnosed at the age of 3. It was overwhelming, to say the least. Nadia does not know life without diabetes. We are blessed to have access to the best medical care, which helps her live the life she wants to live. She has an insulin pump and a continuous glucose monitor. She plays soccer and runs track. She looks like a normal kid, and in most ways she is. But diabetes is always there, 365 days a year, 24/7. This disease is hard and it is cumbersome. We are an emotionally positive family, glass half full, but this disease is still hard on all of us, but especially it's hard on Nadia. She can't eat without calculating how many carbohydrates are in the food so that she can dose for the correct amount of insulin. Her blood sugar levels can go low during soccer games, which forces her to sit out and then treat it and then get back in the game if there's still time. She has to deal with the needles necessary to change insulin pump infusion sites and glucose monitoring sensors in a way that many adults would and still do struggle with. And then the prescriptions and doctor's appointments must be diligently managed. My daughter is brave. She's responsible, and she's miraculous, but it's still so very hard every day, not just for her, but for all those around her. Her siblings, extended family members, teachers, coaches, friends, parents, everyone needs to understand Nadia's needs and how they can help, especially in the case of an emergency. It takes a village to raise a child. It takes a city to raise a child with diabetes. I know that the members of this committee are aware of the realities of diabetes and have championed this cause for years. I am grateful. I was honored to chair JDRF's Children's Congress this past summer, and I know the amazing delegates and guardians you all met are so grateful too. Having you as champions has helped us get to where we are today. In fact, SPD-supported research directly contributed to the development of the incredible devices that Nadia relies on every day. They could still be years in the future if not for the support of the SPD. What my daughter and what every parent of a child with diabetes needs, and what every person affected with diabetes needs, is a cure. Something that removes the thousands of medical decisions we must make every day so that we can focus on everything else in life. For my daughter, that would mean focusing on scoring goals on the soccer field and doing well in school, not whether she will go dangerously low or high in blood sugar in the process. Research can make that happen. The SPD has been foundational to nearly every advance in pursuit of that ultimate goal, which is cures. I'm excited about the progress in therapies to delay T1D onset in those at risk of developing the disease. Anyone who is able to take advantage of delaying T1D onset is receiving an incredible gift: time without T1D. I wish that Nadia could have had that opportunity. I do believe that someday Nadia will receive that ultimate gift: life without T1D. We have made incredible progress towards curing T1D through cell therapies. This research is happening right now. I do not know when she'll receive that gift. No one does, but I do know the best way to bring that day closer is long-term, sustained funding for the Special Diabetes Program. This research must continue. As a mom, I do not want my daughter to face a lifetime with diabetes. With SDP-funded research, I know cures are possible. I know a life free of insulin pumps and monitors and the looming threat of complications is on the horizon, but only if the brilliant minds who have gotten us this far have the resources. They need to get us across that finish line. And until then, we need affordable insulin. The Insulin Act would help us make that more of a reality. So I urge you for your support. Thank you so very much for your time, and I look forward to your questions.
And I now the privilege of introducing the next witness, Dr. Aaron Kowalski, the Chief Executive Officer and President of JDRF. In his role as CEO and President of JDRF, Dr. Kowalski is responsible for advancing and funding type 1 diabetes research by working closely with academics and the type 1 diabetes community. He's also a scientist, and I'm told, and this is apparently not HIPAA protected, you also have type 1 diabetes. Always got to throw that in there, Dr. Kowalski, make sure I don't get busted. Dr. Kowalski has authored a number of type 1 diabetes research articles focusing upon diabetes standards of care and the artificial pancreas. He has a doctorate in microbiology and molecular genetics from Rutgers. I look forward to your testimony, sir. Thank you for joining us.
Thank you. Chairman Sanders, Ranking Member Dr. Cassidy, members of the committee, thank you so much for inviting me to testify in your interest in diabetes. I'm Dr. Aaron Kowalski, CEO of JDRF, the leading global not-for-profit focused on type 1 diabetes. As a scientist by training and, Dr. Cassidy, yes, a person living with type 1 diabetes, I'm honored to work for JDRF for the past 19 years, 4 of which in my current role. I'd like to start with a thank you. Because of your incredible bipartisan support and leadership, and the steadfast leadership of the Senate Diabetes Caucus co-chairs, Senator Collins, who just had to leave, unfortunately, and Senator Shaheen, the Special Diabetes Program, the SDP, and the Special Diabetes Program for Indians, the SDPI, are making a tremendous difference in the lives of people with diabetes and for our hope for the future. These programs have helped fundamentally change what it means to live with type 1 diabetes and have put new life-changing therapies in our hands and have brought us closer to cures. JDRF and our countless volunteers are so grateful for the committee that the committee recognizes the importance of building on this progress with the approval of S1855, the Special Diabetes Program Reauthorization Act. We thank you, and we continue to work with your colleagues to ensure the 2-year, $170 million per year for each program is enacted. Let me highlight for you a few of the many exciting breakthroughs that have resulted in the investment in the SDP that gives us so much hope for a brighter future. Because of SDP funding, we have a new therapy approved, the first ever what we would call disease-modifying therapy. It's called Tzield, that delays the onset of type 1 diabetes and the need for insulin for nearly 3 years. This is landmark. First time in 100 years we've ever changed the course of type 1. Other such therapies are advancing in the research pipeline. This is huge progress. A delay in the onset has a tremendous impact on the daily lives of people at risk for type 1, their families, and the overall healthcare system. To take full advantage of Tzield and therapies on the horizon, we need to ensure widespread screening for the risk factors that trigger type 1. In June, the FDA approved the first ever cell therapy for adults with type 1, those who are unable to maintain average blood glucose levels due to severe episodes of hypoglycemia. This therapy will allow some patients to live without external insulin for several years. This therapy could also have promise for the estimated 8 million people with T2D, type 2, who also rely on insulin administration every single day. This would not have happened without SDP funding. Another game changer for people with diabetes is technology to better manage blood sugar levels. I and many others with type 1 wear an artificial pancreas system, or AP systems. It consists of an insulin pump, a continuous glucose monitor, and a computer program called an algorithm that allows the pump and the CGM to communicate with each other and give the right amount of insulin at the right time. AP systems aren't perfect. They don't replace what you lost when you developed type 1 diabetes, but they do make life better. Better blood sugar control and easier diabetes management. Several systems are on the market now, and next-gen systems are in the research pipeline. Individuals with type 2 are also benefiting from these technologies. Many now use CGM to gain valuable information about how their food, exercise, stress, and other factors impact their lives and help them better manage their blood sugar levels to improve their health. Just this last week, the ADA standards of care were updated to reflect the importance of diabetes devices and recommended them to patients right away when they're diagnosed. Continued support of the SDP will enable several long-term T1D-oriented research programs and clinical trial networks to continue their important work. It will enable researchers to explore new opportunities. For example, highly beneficial SGLT inhibitors, drugs that lower blood sugar by preventing kidneys from reabsorbing glucose, are approved for type 2, but not for people with type 1. We need to develop strategies to ensure these drugs can be safely used by type 1 people, which could reduce the costly and devastating impact of heart and kidney disease. Research for both type 1 and type 2 is critical to gain further understanding, advance therapies, find cures, and JDRF and others are significantly investing in this research. But absent government support and investment, these advancements will slow. The cost of diabetes will rise. We need Congress to move swiftly and enact the SDP and SDPI funding contained in S1855, and until cures, we need affordable insulin for all those who need it to live. JDRF supports the Bipartisan Insulin Act of 2023, led by Senators Collins and Shaheen, and calls on Congress to support its enactment. Thank you again for this opportunity to testify, and I look forward to your questions.
Thank you very much, Dr. Kowalski. This familiar product is a 20-ounce bottle of Coke, contains over 15 teaspoons of sugar, more than twice the recommended daily limit for kids under the age of 18. This is a 12-ounce can of Coke, and according to the Center for Science and the Public Interest, people who drink 1 or 2 cans of Coke a day, quote, have a 26% greater risk of developing type 2 diabetes than people who rarely consume such drinks, and the risks are even greater for young adults. Dr. Telly, do you believe that Coca-Cola and companies that make similar products should be marketing these products to children? Should there be labels on products like Coke warning people that regularly consuming sugary drinks substantially increases their chances of getting type 2 diabetes? Dr. Telly?
We know that food marketing is very effective for kids, and over 50% of our kids are still drinking products like Coke on a daily basis. That consumption has gone down over recent years, but still remains far too high. These kids are being marketed products like Coke in many different ways. Increasingly, this is proliferating on social media and online, where kids aren't even able to identify it as advertising. Kids are seeing nearly 200 ads a week for products like Coke. And so this is really getting into their heads and creating these strong preferences for these products at a very early age. In terms of clear labeling, we have a lot of data both from experiments that we've done here in the US and from global evidence from countries that have implemented these labels, that these labels help people really clearly see when they're looking at the package that this is unhealthy. Coke is a product that is more clear, more consumers know that sodas are unhealthy, but when we think about fruit drinks, those are the products that kids consume the most. Those are products that parents think are healthy. Those are confusing products, and they still contain a lot of sugar. So warning labels would really help parents understand that better.
Apologize for cutting you off. We don't have a lot of time. I want to get to Dr. Gerhardt. According to your testimony, the food and beverage industry has used some of the same tactics as the tobacco industry to get our kids addicted to ultra-processed foods that are high in sugar, salt, and saturated fat. Is that correct? Are we seeing products sold to kids similar to the style used by the tobacco companies?
Yes, so there's documented evidence, given the intertwined histories between the tobacco industries and the processed food industries, that the strategies used to sell, create, market cigarettes were applied very intentionally to improve the profit margins of especially children's sugar-sweetened beverages. And we know that our brains were never developed to handle this level of food reward, the amounts of sugar, how rapidly they're being delivered into the body, that these are really effective at engaging the core neurocircuitry of addiction.
Okay, thank you. Dr. Lipska, Ozempic costs about $12,000 per year in the United States, but just $2,000 a year in Canada and $750 in Germany. What do these very high prices mean for your patients? Do you think your patients would be living healthier lives if we can make these drugs more affordable?
Mr. Chairman, absolutely. These prices are, as I said, outrageous. And what happens is that patients cannot afford those medications, and so they go without. And we know these medications have effects in terms of reducing the risk of heart disease. When people go without, they're at risk for these complications. They would be healthier if they were able to afford them.
Would I be correct in saying not only do people suffer and die unnecessarily, but the cost of the healthcare system increases? If I can't give you a drug, you end up in the hospital. Am I correct on that?
Absolutely, absolutely correct.
Okay. Senator Cassidy?
I'm going to defer to Senator Marshall, but before I do so, I'd like to have unanimous consent. Senator Collins had to leave for a just-called committee hearing. She asked that I submit for the record testimony from the Endocrine Society. Unanimous consent to do so. With that, I defer to Senator Marshall.
Yep. Thank you, Ranking Member, and thank you, Chairman. I sat here in this committee hearing and my head is just spinning been on this committee for 3 years, and I'm not sure we've made any meaningful impact yet on diabetes, a huge epidemic, as we already know this. Certainly there's opportunities to attack the nutrition standpoint, the education standpoint. It's time to stop studying it and forming committees. It's time to move forward with action. I think we all understand the cost of prescription drugs is part of the challenge here. It's interesting to me that in 2022, Americans spent $633 billion on prescriptions. $633 billion. Almost $500 billion of that went through the hands of our pharmacy benefit managers. So 5 out of $6 that Americans spend on prescription drugs go through the hands of pharmacy benefit managers. And of course, there's kickbacks. They give some of that money back to Medicare and insurance providers, and we have no idea who and how much those are going to. But in case you're feeling sorry for the PBMs, they had a profits of $27 billion in 2022. $27 billion was their profit margin. Three PBMs are now ranked 4, 5, and 12 on the Fortune 500 list. So as I look to solving this problem of prescription drugs to treat diabetes, I try to figure out where's the biggest bang for the buck without destroying innovation. And I keep coming back to these pharmacy benefit managers. We've done incredible work so far to address this problem, but our work's not finished. We've sponsored the Drug Act, which is a bipartisan bicameral legislation that would delink administrative fees paid to PBMs from the price of prescription drugs. Rather than paying a percentage of the drug, that there would be a flat fee. Obviously, the PBMs are motivated to, the higher the drug cost, the more they're going to benefit when they get a percentage of that. We've had great co-leads here with Senators Kane and Braun, and we withdrew our amendment because it didn't have a CBO score at the time. But this remains my top priority. We have the CBO estimate. Guess what? This is going to save the federal deficit by $654 million if it's fitted into the PBM Reform Act. Senator Collins said this legislation is literally right on the money, and certainly Senator Collins has been my mentor in trying to figure out what to do with diabetes here in many ways. The underlying issue is that PBMs favor higher-priced brand insulin over insulin biosimilars. We had hoped the biosimilars coming to market would help drive this down, but it remains a challenge. This legislation eliminates the perverse incentives of PBMs to block access to affordable insulin biosimilars and generic drugs. Is there anybody on the panel that would disagree that by delinking this would help drive down the price? Does anyone disagree with that? Okay. I just hope that to have a commitment from our folks, from this committee, that we would continue to work on this, and that somehow we could add this delinking amendment and get it as part of the package to move forward to actually impact the challenges that we have here already. I guess I got a minute and a half left. So let's talk about education and nutrition. I'll defend Coke and Pepsi for a second. They're going a lot to other more healthy drinks. I see them out there. And more I see young people, probably better so than people my age group, making healthier choices. Does anybody have any comments on how we can promote that education in a better way?
Sure. I mean, I think education is really important, and we could do better in our schools by requiring nutrition education, which I believe is not currently required. But we also know that education isn't enough because there are all of these other forces around marketing and pricing and really the confusing food labeling that makes it complicated. So when you're looking at that product, that sugary drink, and it tells you that it's got 100% vitamin C, it can still be hard to understand just how much sugar it has. So there are other things that we could be doing besides education that would help people make healthier choices, because we know people want to do that. It's just currently hard to do that, even when they have education.
Okay, thank you so much. I yield back.
But let me just briefly respond to Senator Marshall. I think you are aware that I consider the high cost of prescription drugs to be one of the great crises facing our healthcare system. We're going to have to take on 1,800 well-paid lobbyists from the pharmaceutical industry here. and all of the campaign contributions that they make. This ain't easy. But I think for the sake of diabetes and so many other illnesses, it should be a major priority of this committee, and I look forward to working with you to make that happen. Senator Hassan, I believe, is next.
Thank you, Mr. Chair and Ranking Member Cassidy, for this hearing. Thank you to our witnesses for being here today. Really helpful testimony. I want to start with a question to you, Dr. Lipska. Last year, 3 major insulin companies announced that they would limit the cost of insulin to $35 a month for all patients. However, we've heard that patients may not actually be getting that discount at the pharmacy counter. In August, Senator Smith and I wrote a letter to Eli Lilly, Novo Nordisk, and Sanofi asking how their companies will ensure that patients can get insulin at this lower price. The responses from the companies confirm that many patients have to navigate a complex system of manufacturer coupons and online applications in order to access low-cost insulin. While these programs allow drug makers to say that their insulin is low cost, they can be really nearly impossible for patients to navigate. So what are you hearing from your patients about the affordability of insulin and other diabetes medications?
Thank you for this question. It's so important, and this is why I'm here. I heard that the companies announced their cuts. I heard them give you their word,
Yeah.
right? And my patients are not getting $35 insulins. I thought initially maybe they're doing something wrong. Let me try it. Let me try to print out the coupon. I asked my nurses in the Yale Diabetes Center, are you paying $35? Are you commercially insured? Are you getting this deal? No, they're not either. So I don't know. The system is really, it's really difficult to navigate. That's true, but we're savvy in our Yale Diabetes Center, and we can't get that deal.
Well, that is very helpful and something that we all need to follow up on, obviously, and I appreciate your work in this area. Dr. Kowalski, I wanted to turn to you and thank you and the JDRF for the important work you're doing to advance breakthrough treatments and one day a cure for type 1 diabetes. In particular, you mentioned some of these clinical trials on one type of cell therapy, and Dr. Cassidy did too, called islet therapy, has been really promising. This therapy, along with biofabrication, is being researched and developed in New Hampshire. And I'd invite the chair and ranking member to New Hampshire to see our biofabrication center and could remove the need for insulin injections for some patients. Dr. Kowalski, I'd like you to speak to the impact that this breakthrough therapy could have on patients with diabetes. I'd also like the chair and ranking member to consider follow-up hearings or work on making sure that the FDA has the approval pathways they need for some of this groundbreaking research.
Excellent. Thank you for the question, Senator Hassan. And I was fortunate to be in Portsmouth at groundbreaking for a cell manufacturing facility that Vertex is building. Cell therapies have the potential for me to take off my pump. And it gives me incredible excitement. For years, I mentioned cell therapies have provided a pathway to cures, but they've required somebody to donate a pancreas upon death. We now have the ability to make insulin-producing cells from stem cells. The 8 million people in the United States on insulin could benefit from these tremendous advancements. And Senator Marshall said the committee hasn't made an impact. They have. You have. The advancements funded by SDP have brought us to the cusp. We are in human trials right now. People are coming off insulin. The first patient has been off insulin for 2 years now. It is absolutely amazing. So the continued support here is to drive this towards what we'd call an immunosuppression-free version, and that's where further research is needed. But the potential is massive. I truly believe I will be cured in my lifetime, as will my brother who lives with type 1 diabetes, and this funding is critical to get us there.
Thank you. One more question for you, Dr. Lipska, before my time is up. As we've heard today, new evidence shows that some diabetes drugs, such as Ozempic, appear to improve other conditions, such as obesity and heart disease. However, with higher demand for these medications, I'm hearing from constituents with diabetes who are experiencing really long delays to get their prescriptions filled. So how can Congress ensure that all populations that can benefit from this medication have access to it?
That's a very important question. Yes, I'm seeing patients, my patients who come in, previously well-controlled, uncontrolled diabetes because they're not able to access their medication. So the supply issue is important, But there's also really important shortages because of the price.
Right.
And I think that's where this committee can really help to ensure that patients can afford these drugs, which are transformative, but not if you cannot take it.
Thank you very much. I yield, Mr. Chair.
I will defer to Senator Budd.
Thank the ranking member, thank the chair, and the witnesses for being here today, including, I think, one from North Carolina. So glad to have you all here. So back in November, so not too long ago, the Wall Street Journal reported on a phenomenon where pharmacy benefit managers, PBMs, they favored drugs with higher list prices. I think Senator Marshall mentioned this phenomenon. For example, one particular brand of insulin sells at $274 per vial, while an unbranded counterpart sells at only $25 per vial. Now, according to the Wall Street Journal, half as many Americans have insurance coverage for the less expensive product as for the higher priced brand, which accounts for about 61% of the prescriptions. Now, this is important because the PBMs that are in there, they preferred coverage for the higher priced medications because they're reimbursed on percentage of the list price. So the proposal that Senator Marshall discussed on delinking PBM reimbursement from the list price, I think that would go a long way in realigning incentives to best serve the interest of patients. Now, a paper published by the American Enterprise Institute, it makes clear that the list price, and I believe the chair mentioned list prices when he was referring to some anti-obesity drugs that were $12,000 or so, but I don't think the list price is really the best way to look at that, and that's not the best indicator of their true cost. Specifically, the study reveals that the rebates that manufacturers pay to those PBMs on anti-obesity medication can be as high as 80% of the list price. So I ask unanimous consent to submit the paper for the record. Thank you, Chairman. Thank you. So the question, Dr. Kowalski, again, thank you for being here. And again, I appreciate your presence in my state of North Carolina. You're making an impact there. And a lot of friends affected by this in similar situation to you. And Natalie, thank you for sharing the story of your daughter, Nadia. So the insulin of 100 years ago, they're not the same insulins that patients are utilizing today, as I understand. There have been countless innovations with insulins, auto-injectors, longer-lasting insulin, some of the references you mentioned. So Dr. Kowalski, could you speak to how public-private partnerships have contributed to some of these advancements?
No, this has been an incredibly important field. When my brother was diagnosed in 1977 and I was diagnosed in 1984, we used cow and pig insulin. It was really, really difficult to manage, incredibly unpredictable. We've seen advancement over advancements in insulin, making insulin easier to use, more effective, and driving better outcomes. Today's insulins are not good enough, and I think this is the balance between innovation and access. JDRF believes we need to continue to innovate in better and better insulins. For example, we've funded what are called glucose-responsive insulins that would only work when your body needs them. These would be transformative. That said, an insulin that's generic and off the patent for many years needs to be accessible. No one with type 1 diabetes should go without insulin. You die. If you took away my insulin pump, I would die within a week. So this rationing of an insulin is an unacceptable outcome in the United States of America. So this is a balance that we need to strike, but the advancements that continue are critically important. We know the average person with diabetes right now in the United States is not achieving their goals. We need to do better.
Appreciate you all being here. I yield the floor.
Thank you, Senator Budd. Senator Smith.
Thank you, Chair. Thanks very much for this hearing, and thanks to all of you for being here. I want to just put a note on what Senator Hassan was asking about related to how people can get access to this, what seems like mythical $35 insulin. And, you know, I hear from Minnesotans every single day who tell me that they are rationing this medicine that keeps them alive. And then we have these big companies come in and tell us, oh, it's not us, we're doing everything that we possibly can. We're trying, you know, we're making our products available. And I don't believe it. I don't think that's what's happening. And Mr. Chair, I think that this is completely unacceptable, and obviously it just pisses me off. I really appreciate your testimony about how food is being engineered by these big food companies to be addictive and the impact that that has on people's health, their physical health, their mental health. It is pervasive. I also have been really encouraged by some of the preliminary results that we're seeing for around enrolling diabetic or pre-diabetic patients in food as medicine initiatives. On the other hand, when you actually are consuming real food, it has a big impact on the quality of your health. And these studies, as I understand it, are showing decreases in AIC levels, increases in food security, and improvements in self-management of diabetes. So Dr. Telly and Dr. Gerhardt, could you talk a little bit about this? What is the potential of this? What is the correlation between access to healthy foods and the risk of diabetes? And what should we be doing to take down some of the barriers that make it difficult for providers to support that kind of therapy?
Thank you so much for this really important question. We're actually doing work in my lab right now, taking a food as medicine perspective. We have funding from the Eisenberg Family Depression Center at the University of Michigan. And again, I'm seeing as a clinical psychologist just this huge mental health epidemic in adolescents and teens.
Yep.
And we know that the majority of teens are maybe getting more calories from ultra-processed foods than any other developmental stage young children or adults. And yet we're seeing that when you can move people to real, nourishing, whole foods, that it doesn't just help improve their physical health, but their mental well-being. And so we're actually doing a trial to work with a company, Fresh and Lean, to deliver affordable, convenient, minimally processed, ready-to-go meal packages for people as a potential treatment for depression. And I think we need to think not just about cost and protecting against marketing, but part of what ultra-processed foods do is they're super convenient. They've been designed so you can just pour them in your mouth while you're driving your car.
And cheap.
And cheap. And so thinking about ways to make nutritious, nourishing food convenient, accessible, and affordable so it can compete with these hyper-palatable foods is key.
Thank you.
The food as medicine data so far are very promising. It shows that it reduces food insecurity, increases intake of fruits and vegetables, and reduces A1C. So that's great. From a prevention perspective, though, it means that somebody still has to get sick and access the healthcare system in order to get those prescriptions. And in an ideal world, we would see that people had access to those foods as part of their daily lives before they develop obesity or diabetes.
I really appreciate that, and it gets to a whole other realm of questions that we could be asking if we were on the Ag Committee around challenges with concentration in the food sector, what that means for how people can get food deserts in rural communities and urban communities, particularly Black and brown communities. There's a lot of work to be done there. I want to just follow up on this for a minute more. We know that American Indian and Alaska Native adults are much more likely than white adults to be diagnosed with diabetes. And we also know that the Special Diabetes Program for Native people, which funds community-based initiatives, provides access to people to traditional food, native food, is really effective because it incorporates traditional practices and traditional foods in combination with clinical interventions. It seems like there's a correlation between what we're talking about here. Maybe I just have a few seconds more. Dr. Lipska, would you like to talk a bit about why this kind of program can be so effective?
Absolutely. I actually spent some time working on the Navajo Reservation, so I'm very familiar with the setting and the rates of diabetes. You know, we have to tailor the foods so they're culturally appropriate for our patients, and we have to, but I just want to say I think we have to go really way upstream. I know we're out of time with these interventions because it's much harder to intervene, as you said, once people already have prediabetes or obesity.
Thank you very much. Thanks, Mr. Chair.
Thank you. Senator Cassidy.
Senator Braun, would you like to go? Are you ready?
Thank you. I'm ready. This has been a subject of interest for me way before I got to the U.S. Senate. When you're talking about diabetes, drugs, prevention, remediation, I wrestled with it to where I was at the point of frustration. There was nothing that you couldn't generally solve in running a business other than health care, which generally ended up how lucky you were that it was only going up 5 to 10% each year. So when we were at the point where I could really do something about it, large enough to self-insure, did three simple things. Number one, I realized none of my employees were healthcare consumers. They were the inelastic demanders of remediation, generally wanting the plan to pay for everything. And in the same way, if your private plan doesn't pay for it, people look to government to do it. It's created a system that has given us a bizarre kind of cross-purpose of where it doesn't jibe with what works in most other markets. What I did, they became healthcare consumers. I gave them every wellness tool, including a free biometric screening. I didn't coddle them. You were going to pay more if you wouldn't take that. And you know what it's done? It has lowered healthcare costs. We've been doing that 15 years and have not had a premium increase. Unlike Dr. Lipska and maybe Dr. Kowalski, how much of what we're talking about here is part of a broken system that is now driven mostly by huge hospitals that love opaqueness, no transparency, and insurance companies that have gone way beyond indemnification to where they're in on everything and they grab roughly 15% of the healthcare dollar that's purely administrative. We're talking about things, I think, on the side of how you fix diabetes and other chronic ailments. What about fixing the system itself? I'd love for you, Dr. Lipska, to weigh in, and then Dr. Kowalski.
Thank you for that question. I agree with you that our system is broken. In terms of, how do we fix this for diabetes in particular, to prevent diabetes, to prevent obesity? I think the healthcare system needs to serve the needs of the patients who develop these conditions, but I think we have to, again, go upstream from the healthcare system in order to prevent people from getting sick in the first place. And I think that's critical. That's going to save us money and, in the long run, to keep people healthy. And I think that's upstream from the healthcare system.
So I'll just make a quick statement because I'm going to come in with a research perspective, but start by saying, we're talking a lot about obesity and diet, that being obese does not mean you're going to get diabetes. And sometimes I worry we stigmatize people with type 2 diabetes by saying, and some of our colleagues said this, by you just stop eating and you'll get diabetes. This is a genetically inherited disease.
And I know that. I'm asking about the framework within which you'd like to see that would address it and many other things.
Absolutely. So when we think at JDRF, our mission statement is accelerating life-changing breakthroughs to cure, prevent, and better treat T1D and its complications. And I always take those words very literally and significantly, meaning your life's not changed if you don't have access to better care. And if the system provides barriers, as Senator Sanders said, to drugs that could improve your care and your life and your health, then we haven't succeeded in our mission.
And I'd agree with that. And I think that's a particularity that will weigh in to be helpful. Let me tell you what I think is a solution to this and the extremely high cost of health care, access, and all of it. And proud to say that later today, Senator Sanders and I will be introducing a bill called the Healthcare Price Transparency Act. I've been working on this for the 5 years I've been in the Senate, and I think it is the umbrella that finally takes us to solutions for this and many other things. Briefly, let me tell you some of the things it's going to do. It's going to require machine-readable files of all negotiated rates and cash prices between plans and providers, not estimates. It's going to require pricing data standards, including all billing codes for services. It's going to require actual prices for 300 shoppable services with all services by 2025. It's going to require a testing by executives that all prices are accurate and complete. It's going to prevent preemption of state price transparency rules, codify the Transparency coverage rule, and it's going to provide group health plans the right to access, audit, and review claims and counter data. Thank you, Senator Sanders and Senator Smith, for being on it. I hope to get all Republicans and Democrats on a bill that'll fix many aspects of health care.
Thank you, Senator Braun. Senator Hickenlooper.
Thank you, Mr. Chair. Thank all of you for being here. I've got a few questions, so I'm going to hope you can be very concise. This morning we've discussed what more we need to do to address upstream causes of obesity that are leading to high rates of diabetes in our country. It's particularly important that we think about what we can do early on to ensure fewer of our kids end up with type 2 diabetes. In addition to nutrition, one major tool, which has been talked about somewhat, to improve overall health and wellness is access to green spaces and outdoor activity. Green spaces and getting kids into outdoor recreation can help promote the kind of lifestyle that keeps kids healthy. 1 in 3 Americans, including 28 million children, don't have access to green space within a half a mile. We're working on legislation to create a federal office of outdoor recreation, which will help ensure equitable access to recreation in all communities. So we'll start with Dr. Gearhart and Dr. Telly. Can you discuss the benefit that physical activity with healthy eating, along with healthy eating, can have in delaying or preventing the onset of type 2 diabetes?
So we see that physical activity and nature can play a big role in our overall mental health and well-being. We do see that the role of nutrition and diet can kind of swamp some of those effects. But I think you're right that it's really got to be multi-pronged and multifaceted, and we need to take holistic views, but also invest our energy and resources where it's going to make the biggest bang for our buck.
Yeah, to build on that, the diabetes prevention program showed that the combination of physical activity and diet changes were tremendously effective at preventing type 2 diabetes. But at the same time, going back to Senator Sanders showing us that can of Coke, we know that it's really, really easy to drink a can of Coke, and that would require exercising, running 1.5 miles to offset that can of Coke. And so it's really important to, in my view, really prioritize nutrition, coupled, of course, with physical activity, to promote overall fitness.
Great, thank you so much. Community health centers place an emphasis on integrated care models, take a comprehensive approach to patient care, focusing not only on treatment but prevention, nutrition, exercise, other social determinants of health. We've seen some compelling data on this committee that shows community health centers are more successful at helping patients with hypertension and diabetes control these issues, which really is remarkable because community health centers are more and more dealing with complex chronic conditions. So Dr. Lipska, what can other healthcare providers learn from community health centers and their approach to caring for diabetes patients?
Thank you. And I think it has to do a lot with the fact that community health centers take that holistic population view as opposed to the rest of healthcare, which often takes care of the patient in front of you, bill for the service, and then that's it, right? And I think that if we have these systems where you're responsible for the care of the population of patients, you're going to put more emphasis on prevention of disease rather than just treatment of complications when they occur. So I think we can all learn a lot from that. I think that they're doing a great job.
I agree. And just one other point on that, or separate than that, is consuming these ultra-processed foods like sugary drinks and all these things we've been talking about also connects with higher rates of dementia later in life. Didn't know whether you or any of the others would like to comment on that.
Yes, there's been some people who've even started to think a little bit about Alzheimer's and dementia as type 3 diabetes.
I've heard
has
that
been
from the labs.
Discussed a bit. And I could say we've done research with the National Poll on Healthy Aging at the University of Michigan that found in older adults, 13% endorsed clinically significant signs of addiction in their intake of ultra-processed foods, and that was associated with higher mental health, physical difficulties, and overall a tendency to have a lower quality of life. And so I think older adults are a really key population whose increase of ultra-processed foods has been increasing remarkably over the last couple decades.
Got it. Great. Thank you. And just very quickly, Ms. Stanback, the National Institute of Diabetes and Digestive and Kidney Diseases at NIH funds this critical research across the country University of Colorado, Denver Diabetes Research Center, with this important support is spearheading research into type 1 and type 2 diabetes. They also run a program to recruit young faculty into diabetes-related research. Your experience, first with your brother and then with your daughter Nadia, highlights the importance of prioritizing research and making sure future scientists are focusing on treatment. How have the recent medical breakthroughs, even over the course of Nadia's life, changed her experience of living with type 1?
Peace of mind. A lot of us are talking about the pharmaceuticals and the medicines that help people with type 1 diabetes, but it also presents a very serious mental burden that presents in the form of burnout and other things that are detrimental to the health of people living with type 1 diabetes. So her insulin pump and the CGM gives not only her, but me also peace of mind and being able to manage the cumbersome disease.
Right, thank you. Thank you all. Appreciate you spending the time to be here. I yield back to the chair.
Thank you. Senator Cassidy?
We have 5 minutes, so if I interrupt you, I'm not being rude, or maybe I'm being rude, but that's the reason. Dr. Kowalski, you mentioned risk factors for type 1 diabetes, but I thought, well, what is there besides genetics and genetics? What are the risk factors? Are there other risk factors that we don't know about?
Well, I think you're hearing that in both forms of diabetes, there's
Just type 1.
Okay, it's genetics and an environmental factor, and if we could find that environmental factor, we could stop this disease.
So when you mention that we need to focus upon the research, it's just that this is to be developed. It's not that we know it now. You said that we need to study those who have the risk factors, but the principal risk factor would be like Ms. Dambach's family. My gosh, and maybe yours, because you mentioned your brother having it.
Yeah, no, there's definitely a genetic component in type 1 diabetes. We know that well. But if you have an identical twin, it's not 100% that the second twin, if the first one develops it, will get it. So we have, for example, the SCP is funding a very, very important study called Telly that tracks from in utero to adulthood children at high risk. And we're looking at environmental factors that could be triggering the disease. That will stop.
Now, let me interrupt
type
you.
1.
I graduated from med school in '83, and they've been talking about it since '83. So obviously, it's pretty difficult to tease out what those environmental factors are.
Very difficult, but we do have a number of candidates that are moving into human clinical trials, and we believe we will get there.
That's fantastic. Ms. Stambach, Dr. Lipska mentioned that in her clinic, the workers there have a hard time getting $35 insulin. We know what we're told up here, but we often don't know what we know. You're the person who's been kind of living with this. What is your experience in terms of, and I ask this not knowing the answer, what is your experience in terms of getting affordable insulin?
Our insulin is only affordable because we're paying top tier for our private insurance, but I've also not seen or
Now, let
heard
me
of
ask you, do you have any insight into what your pharmacy benefit manager, because we've been told pharmacy benefit managers deliberately do not take the low-cost insulin, but rather get the higher-cost insulin because, frankly, the PBMs allegedly make more money by costing you more money. Do you have any insight into that?
I don't. I just know that we selected the highest tier of the insurance provided by my employer to make sure that we could not have any inhibitions when it comes to choice or selection of insulin.
That's great. And Dr. Lipska, do y'all have any insight into what Yale does for its PBMs? Because again, this has come up continuously, and this is the big rub. Eli Lilly says, hey, listen, we're giving it for $35. Yeah, there's a tax, there's a dispensing fee, but our cost is $35. And the PBMs allegedly are saying, no, we're going to give you the top dollar, and we're not going to take this one. Do you have any, when you inquire about this, do you know whether that extra cost being paid is due to the PBM or to the drug company?
It's a great question. I don't know. I honestly haven't been able to get to the bottom of why this happens, because it's so difficult.
So let me ask then, and this may come to you. It's my understanding that on some of these processed foods, it's fructose more than glucose or sucrose, which is the problem. And that fructose is more quickly absorbed and causes a greater sugar high and kind of the greater sugar low, so therefore you want another hit. Now, again, I haven't looked at this for some time, but is that still kind of the thought?
Yeah, I think, I don't know if the other panelists want to answer that as well, since I treat diabetes, but I'm familiar with some of that research, and I understand that that's true, that fructose does activate those reward systems.
Could one of y'all answer that quickly, please?
That is true, but the high fructose corn syrup that we're consuming is actually very similar to sugar from a chemical composition perspective.
The fructose?
The main, yes. The
Yeah,
main,
but the fructose is more quickly absorbed.
the main issue is also that we're consuming it via liquid forms, which means that it's much more rapidly digested. And that's true for ultra-processed foods as well. The way that those foods are made means that they are metabolized much more
I
rapidly.
get that, yeah.
Causing
The more fiber, apple juice is absorbed more rapidly than applesauce, which is more rapidly than an apple.
Exactly.
More fiber is slower absorption. But fructose is the independent factor, and it does seem like fructose is a particular issue here. I'll just point that out. Ms. Stambach, coming back to you, again, we've had these kind of conversations as regards PBMs. When you change insurance companies, because periodically employers do, are they making you go through a prior authorization process for whatever your daughter's currently on? A brand new one? No, this didn't work before, but you got to go through it once more just to satisfy our requirements?
No, not with our private insurance. That's through my employer.
And are you have a big employer or a small employer?
It's fairly large.
Do you mind telling us for whom you
I work for AMN Healthcare, medical staffing.
Yes, that's a pretty big company. Okay. Well, I'm almost out of time, but I thank you all.
Thank you. Senator Kane.
Thank you, Chair Sanders, and great hearing, great witnesses. I'd like to put an unusual document into the record. It's a JDRF 2023 Children's Congress scrapbook. A bunch of students in Virginia who have diabetes told their stories, and they're Emery Ellis, Maddie Hawkins, Riley Kitts, Carson Owen, Jack Samples, Jan Vanden Eykel, and I think these are worthy testimonies. And I just want to read one that was interesting from Maddie Hawkins. She's in a family where mom, dad, and a brother. The mother doesn't have diabetes. All the others have type 1 diabetes. And listen to this. My dad was diagnosed with diabetes before I was even born, and my brother diagnosed in 2020. So it's always crazy at my house. There's always some alarm going off, always someone who needs to treat their blood sugar. My mom's goal in life is for all of us to have the same blood sugar at the same time, but that hasn't happened yet. Still, at the end of the day, sharing diabetes creates a sense of camaraderie, and then there's a picture of the dad and the two kids who share this camaraderie because they have diabetes. I would just like to put that into the record.
Without objection.
And focusing on young people, during the height of the pandemic, Congress provided schools with a lot of flexibilities around meals. 1 in 5 kids in the U.S. live without constant access to adequate food, and this temporary expansion during COVID allowed students, especially those in high-need areas, to have much more access to meals that were nutritious. Now the pandemic-era policy has ended. Several states have enacted legislation allowing for universal free school meals. In Virginia, there are currently about 511 schools that have adopted the community eligibility provision where eligible schools can offer meals at no cost to all students. I'm heartened to see this uptick in the CEP in my home state. Dr. Telly, what impact does the nutritional value of school lunches have on students' health, and what can Congress do to improve health outcomes for kids?
School foods are probably the #1 way that we could promote healthier diets among kids and ultimately prevent diabetes. Kids consume 1/3 of their daily calories in school, so this is incredibly important. Universal school meals are critical because it ensures that all kids have access to food. We know that adequate nutrition is not only important for health and growth, but it promotes learning outcomes. And it also means that kids aren't stigmatized for receiving, when only some kids get this benefit. So in addition to universal school meals, as I said in my testimony, really making sure that our schools are free from corporate food marketing, ultra-processed foods, sugary drinks, the marketing and advertisement and sales of those products to our kids is currently a major problem. And so reducing or eliminating that would make huge progress.
Let me ask another question. I've heard an interesting policy debate, and the question is, should SNAP benefits be usable to purchase unhealthy and ultra-processed foods? Those who say yes say you shouldn't have a separate standard for people using a SNAP benefit card and person using dollars and cents. Those who say that SNAP benefits shouldn't be used say, why would we want to pay tax dollars to enable people to purchase foods that make them sick or kill them? And if SNAP benefits weren't usable for unhealthy foods, the food retailers and grocery stores that are in neighborhoods where there's a high percentage of SNAP recipients would have more of a motive to offer more healthy food options. What do y'all think about that debate?
Yeah, I can weigh in on this. I've tried to do research in the past on this and wasn't able to receive funding. I think it's really important to make sure that people who are using SNAP have dignity and choice. At the same time, when we think about restricting, I think the clear place where we would start with that is around sugary drinks. I think there's an argument to be made that those may not even be considered as foods. They provide no nutritional value, and the health harms are so very clear that SNAP is currently not allowed to use for like hot meals or alcohol or things like that. And I could see putting sugary drinks into that category.
Other thoughts from other panelists? Dr. Lipska?
I think the problem is that those foods are also, the unhealthy foods are also cheaper, right? So then your SNAP benefit is going to go potentially a longer way if you can make those foods, the healthy foods, more affordable.
Yeah.
That would make it easier.
I mean, beyond restricting, the Double Up Bucks program is a really effective strategy to, instead of saying, well, you can't buy this, to incentivize people to buy fruits and vegetables by giving them more money to do that.
Thank you. Mention, which isn't really a question, is I know we're talking about doing work on the Older Americans Act next year, and I think there's a lot in this space that really we could do as part of a reauthorization of the Older Americans Act that has been touched on in the testimony earlier, and look forward to working with you on that.
I agree. Okay. Nick Casey.
Thank you, Mr. Chairman. I want to thank the panel, and Sarah wasn't here earlier. We had an Aging Committee hearing that I was chairing that overlapped, so we have your testimony, and I know that Sarah and my team has been here for the whole hearing. I wanted to thank the witnesses for your testimony, bringing both experience and expertise to these issues. And I know the hearing touched on a number of critical issues relating to diabetes, and including the high cost of insulin. I was one of the, as many were, co-sponsor of Senator Warnock's bill that proposed a cap on co-payments for insulin in the commercial market of $35 a month. That was similar to what we passed in the Inflation Reduction Act for Medicare Part D beneficiaries. So I just have two questions. Dr. Kowalski, I'll start with you. Type 1 diabetes is often perceived as a disease of children and young adults, but as healthcare for people living with diabetes has improved, it is truly a disease that can affect people a much longer time period throughout their lives, as you know. Are there specific challenges or factors we should consider with respect to older adults with type 1 diabetes? That's the first part of the question. And then second, are there medical issues that need more research or policy changes specific to the needs of older adults that you'd recommend?
Well, the great news is people with type 1 diabetes are living longer. When I was diagnosed, we were told we would have significant reduction in lifespan, and my brother and I, fortunately, are doing well, and many people. That said, we know that older adults are particularly susceptible to severe hypoglycemia. Hypoglycemia unawareness, which can cause falls and broken bones. And unfortunately, broken bones are another issue in older adults with diabetes. So that's an area. Reducing hypoglycemia is a big, big priority. As we drive better glucose control, we know that complications of diabetes that have been mentioned by a number of panelists, heart and kidney in particular, are forestalled, but don't go away. So the risk of long-term kidney disease, which is a major driver of CMS cost, is another area where we are making progress. We've mentioned the benefits of these new drugs, GLPs and SGLT inhibitors, can reduce diabetic kidney disease and cardiovascular disease, a particular problem in older adults with type 1 and type 2 diabetes. So this is an opportunity to reduce costs and improve care.
Thanks very much. Dr. Telly, did I pronounce that right? Nutrition for children is obviously fundamental, as so many have made reference to. I introduced a bill that focused on what I believe are, what should be the 5 freedoms for children. One of them is a freedom from hunger, in addition to health care and education and so much else that we want to provide our kids. At the end of your written testimony, I think it's on page 6, you mentioned the need for more research into nutrition science. What are some of the current gaps in our knowledge about nutrition, especially as it relates to kids?
So one of the gaps that we've been talking a lot about is the fact that we still don't have a really good understanding for the biological mechanisms of how ultra-processed foods work. They're such complex substances. Kevin Hall at the NIH did a wonderful trial that was the first step in showing this, but there have been no additional studies to replicate that, to look at this issue in kids, and to really go farther to really isolate what those effects are. So I think that would be the first piece of this. And then the second piece is understanding from a population level perspective. We're not thinking about how to treat these kids. We're trying to think about what policies work more broadly to prevent hunger and also promote healthy diets, because those things often kind of go hand in hand. We have a lot of kids who are hungry and also consuming diets that are really high in sugary drinks and ultra-processed foods.
Thanks very much. Thanks, Mr. Chairman.
Sen Cassidy, you want a brief closing remark?
Yeah, Dr. Kowalski, I know you would agree with me totally, but just for the record, you mentioned that obesity does not necessarily lead to type 2 diabetes, but let's not imply that obesity does not have other problems associated with it. Hip replacements, joint replacements, heart disease, hypertension, gallstones. We mentioned earlier about Alzheimer's, on and on and on. And so I'm a big proponent for obesity research. If the metabolic syndrome is almost always triggered by obesity, and I used to tell my medical students it's a hydra head monster, and diabetes is one of those, but there's many others as well. I think we need to be asking the NIH and CDC to focus more attention upon obesity in of itself. So, and I know you agree with that, but just for the record.
I agree.
That was a brief remark. Good. Well, let me thank all of our witnesses. I thought a very informative hearing, and I thank all of you for being here. And we've touched on a lot of issues, the need for more research in type 1 diabetes, the need to address the crisis in our kids becoming too heavy and the foods that they're eating, what they're drinking, and the need for affordable treatments. We've covered a lot of territory that I hope this committee will effectively deal with. But thank you all very much for being here. And with that, this is the end of our hearing today. And for any senators who wish to ask additional questions for the record will be due in 10 business days, December 29th at 5 p.m. The committee stands adjourned. Thank you all.